Welcome to the flavor of the month, everybody. And I'm Dr. Dhivya Prathiba. I have been associated with Agarwals for the past 13 years. And I'm now as the CMO of Through a True branch in Agarwal Hospital. And I would like to thank the Education Committee for giving me this opportunity and for arranging these monthly webinars. I know how difficult it is to get speakers, to get panelists, and especially to get wonderful attendees like you for the webinars every month. And they have completed 15 episodes, and today is our 16th episode. And if any one of you is interested in watching those past 15 episodes, it is available in our YouTube channel, Education Committee YouTube channel. You can go and watch. And this video, if you want to rewatch it again, it will be available in a short while. So having that been said, I would like to introduce our speaker for the day, Dr. Ram Mirlay. He's a cataract surgeon specializing in toric and multifocal IOL surgeries for the past 20 plus years. He has implanted over 3,000 toric lenses, 2,500 multifocal IOLs in his hospital. He joined Agarwals in 2019, and now he heads the Shivaji Nagar branch, SVR Mirlay Eye Care Hospital. His practice tagline is, this is very interesting, glasses-free vision surgery for cataract patients. Every cataract surgeon's dream tagline, I think. Welcome, sir. And I would like to welcome our panelist, Dr. Bhanu Prakash, who is our senior consultant in Agarwal Panchakutta branch. He's a cataract, cornea, and refractive surgeon. He's also a phaco, ICL, and smile trainer. Welcome you, sir.
Yeah,
I would
thank you.
request all the participants to mute themselves except for the speaker. If you have any questions, we can put it in the chat box. We'll have a discussion at the end of the session. So you can take over, sir.
Thank you, Dr. Dhivya, and thank you, Dr. Bhanu Prakash, for being around, and thanks for all the participants who makes the session worthwhile. So, toric lenses are very easy to do. Just like anything that we learn new, there are some steps. And if those steps are omitted, the project looks difficult. If you follow those steps, it is as easy as phacoemulsification, actually much easier. So let me outline to you in this particular talk, which, as Dr. Dhivya said, will also be a kind of a reference on in the YouTube channel of where we stand. So let's look at some data. I won't go into the basics by defining toric and all that. All of us know we are cataract surgeons here. So the worldwide data shows that of every 100 IOLs manufactured or sold, 4 are torics. Okay. So this is the worldwide data. European Union alone, the data is 6%. So they're not very different from the bulk of Indian doctors. Most of the persons in India have either a near 0% toric practice or about a small toric number practice. In Bangalore, there are, to my knowledge, 4 practices which are maxed out in toric, which is at 20% torics. Okay, outside of my SVR branch. So why is this so? Now, how much astigmatism is there in the population? If you ask, it's about 20 to 25% of our patients have astigmatism. This is known to us in our own experience. If you look at, this is 0.75 and above. If you look at 0.5 cylinder plus or minus, then the number goes up to 40 to 45%. The European and American data claims that astigmatism in human adults is 45%. Whatever. So for my talk, I have taken 0.75% as the starting point for cylindrical correction, because we used to do 1 cylinder and above. Now we have the confidence, we do 0.75 cylinder. We do not see the need to do 0.5 cylinder. So that is your first point of prevalence of astigmatism. Now, why should you get into torics? Thinks life is fine with monofocals. The reasons why we need to get into torics are as follows. It's a premium surgical practice, very high patient satisfaction because they get glasses-free vision. When it comes to why torics, glasses-free vision is what will be delivered by the surgeon and the practice for who use the toric lenses. Now, toric lenses are charged high. For a commercial company like Agarwals, it is an EBITDA-rich product. The very high patient satisfaction gives you a very good return rate and word-of-mouth spread. If you go to this particular doctor, and you don't need glasses at all forever for distance. We have the same taglines. When we say glasses-free vision, there are two taglines with us. Glasses-free vision is used for our multifocal practice, and glasses-free vision for distance is what we put for our toric lenses, because they do need reading glasses. Stepping into toric surgery, there are three basic steps in stepping into toric surgery. The first is your biometry has to be accurate. So toric lenses cannot be done by a surgeon if his team, which is your optometric team, does not have an accuracy of at least 95% on the spot, which means 95% of your cataract patients should have less than 0.5 cylinder residual end of the second month. Without this, you're not going to be able to deliver glasses-free vision, which is what we need to deliver in doing the toric practice. Okay. Now, so it's the biometry which we are going to focus on in this talk largely. The second suggestion that I'm going to offer you is a method of practicing toric cataract surgery without torics, using monofocal lenses, where your risk is absolutely zero. And then we proceed on to the first implant. We call this toric without toric lenses. What is the reason why 95% of the cataracts in the world, especially in cities, are done without toric practice, without toric lenses being a significant part of their practice? The initial poor results will come if you choose the wrong lens design or if your biometry is inaccurate. Second, in the mind of a surgeon who's not used much toric, or who's used a few torics with not good results, which means you need residual correction, there is a fear, and they feel it's better to stay in the safe zone or zone of comfort of the doctor. So these are the main reasons why there is a little fear of torics. Now, as you know very well, if your biometry is accurate, the implantation of the toric lens is no different from any other lens. And to dial a toric lens into the proper optical axis is extremely simple. We are all doing that anyway for our lenses. When you want to joggle it around a bit and center it properly, you're anyway dialing the lenses. So in terms of surgical learning and skill, it is child's play, near zero, no-brainer. Okay, so let's now go back and concentrate on what is the method of biometry we use, and why is it different from the normal, and what are the problems which cause, what is the worldwide problem which makes toric calculation inaccurate? Let's look at that first. Okay. Now let's go back to a little bit of a basic anatomy of the eye. You heard of anterior corneal astigmatism. You heard of astigmatism. But there are two types of astigmatism that is not even spoken of, not even by Carl Zeiss, the company which makes amongst the best IOL masters. And that's called lenticular astigmatism. The presumption by the entire world industry is that lenses are absolutely perfect. The human lens, the normal phaco, is absolutely perfect. It has no distortion, it has no aberration, and it is perfect, and its astigmatism is zero. This is the basic funda which creates errors in your computation of the correct IOL power. Now, let us assume I had this early experience where there was a person, I put in a multifocal lens, and the astigmatism was zero. But when I finished the surgery, I landed up with -2, and it was not a corneal astigmatism. It was a lens which had a -2 cylinder compensated by a +2 cylinder on the intraocular original lens. So this led me to do some of my discoveries. And now I will share with you how we modify and improve the output from the IOL Master 500. So a few more points on biometry. We use an IOL Master 500. The data I'm telling you is extremely confident. I'm very confident of this data. The IOL Master 500 and similar optical biometers of that generation has a penetration capacity of 75% in Indian cataracts, which means about 20 to 25%, like brown cataracts, black cataracts, PPCs, it's not able to measure. Now, based on this fact, it is important that such cases Along with those where you get a printout for 75% of those patients with the IOL master, we need to have a cross-checking method and find out with our experience what is the very likely power of that particular lens. So apart from the cross-checking method, we also have an escape route. We have a special consent form which is designed very, very truthfully, factually, so the patients are not promised a glasses-free vision and then not delivered upon. So let me go to this is a printout from an IOL Master 500. We call this the Toric calculation slide. So what we do here differently is that for all astigmatic patients, we take the corneal keratometry, corneal K. We do not go by the IOL Master K. Why? The IOL Master K is based on an infrared technology which measures the astigmatism of the total eye. So that includes corneal astigmatism plus the lenticular astigmatism. I want to delete the lenticular component of the measurement. So I can't do this here. So we have a simple Javel-Schwartz keratometer, but you can use any keratometer you want, but you should use a non-smart keratometer. Its software is the problem. So use that keratometer and find out the steep K and the flat K and get the base of the IOL that is required. The cylinder is already known by the difference between flat K and steep K. So this is how we calculate the IOL power. Now, if it's a hard cataract or a mature cataract and you can't get the IOL master readout, we repeat the same using the skill of an accurate optometrist. And this is where the team comes, the best of Spike. This is point number one. Second thing we do, if Dorothy can show the slide on that is called the biometry accuracy slide, we have 9 steps of confirming of trying to find out whether the number we have, IOL number we have is accurate or not. And first we take the visual history till the age of 40, age at which the first presbyopic glasses was given, age of first glasses, if possible, whether it was myopic, old spectacle, whether LASIK was done or not, fellow eye axial length, difference between the left and the right eye axial length, and the difference between the left and the right eye axial IOL power. Okay, so these are the parameters we take. For example, you know by our experience that if a person has a -4 spectacle power, generally the IOL power will be around +16. So we have these correlations already with us. So we have a chart as well. And though it is not accurate, it helps you to reconfirm and make sure that whatever we are doing is less inaccurate. I won't say accurate, but there's two things that we are doing of cross-checking with 7 and rechecking all the values moment there is a difference between the left and the right eye. Okay, so these are the 2 slides we have just covered. This is the next topic we have is that in spite of all our efforts, we may go wrong and there may be a residual power left. So we have a special consent form where we explain to the patient that our accuracy is only about 90 to 95%. There is a 5 to 10% chance that after we do everything, you will still require a small power glasses for far. So not merely do we explain this, but we have this written out on a printed format and we make the patient or the attender copy it in their handwriting and sign it. That is the special precaution we take. So we have 0 problems. If they come back disappointed, we said, listen, we told you about it. You understood it. You have written it here. Now that's how it is. We are not a perfect German accuracy machine. This is how it is. So this is called the escape route. So how do you counsel a toric patient? Now this is a challenge because it is difficult to explain astigmatism to a layperson. So what we do is that we show them the trial lens set and we show them the prescription standard format used worldwide. So pointing to the trial lens set, we tell them all patients have a main power and some patients have a side power. So we point to the toric lenses and call them side power. We point to the spherical lens and call them main power. This is easily understandable by most people. So we tell them, if you take a lens only with the main power, then you'll have to wear the side power on a spectacle over your face after the surgery to see clearly. But if you want main power and side power together inside your eye, we call them toric or astigmatic lenses, and then you'll be glasses free lifelong. So this is our simple demonstrated toric counseling method. Now, because this lens has a side power and a main power, a sort of a double lens, the cost is much higher. So this is the way we do toric counseling. Toric marking, we always do a primary marking. Picture is not a very good angle picture, but you use the standard primary marker to mark 0, 180 and 90. Then we do the secondary markings as per the possible access required by for the patient. Okay. So you can do markings in many ways. You can do it on the slit lamp like how Dr. Bhanu does, or many others do. And that's left to the choice of the person. The important thing is to do it accurately. So we do the secondary mark. Once the lens is implanted, we turn the markings on the lens to align and coincide with the markings on the cornea. We use the standard pens that the companies give us, and there's nothing special or difficult about this. Now, I'd like to introduce a very easy, 100% safe method of becoming an expert toric surgeon without putting in a single toric lens. This is how it goes. Choose any of your next 10 patients and start with the primary marking. It will always be 0, 90, 180. For your first patient, I suggest that you do a 30-degree marking, secondary marking on the table, or a 45, or a 60, or a 90. And then forget about the toric lens, continue with your surgery, and implant your whatever lens you're implanting, implant. Push the optic haptic junction to the desired angle that you have decided. If it is 30 or 45 degrees, put it at 30 degrees or 45 degrees and rotate it into that particular. Examine on the slit lamp next morning and see if that angle of 45 degrees that you have implanted the lens in is maintained. Repeat for 10 cases, you will get full confidence. As simple as that. You don't have to do primary and secondary marking on a real toric lens. So this is what I call toric without torics. I have said 10 cases, you can do 20, whatever number you want. Now we come to, so I use a plate haptic lens, the Carl Zeiss 709 toric monofocal. For multifocal toric, I use the 9.3 line Carl Zeiss lens. No special favor for the company, but I will discuss in the next few slides what kind of a lens would be ideal in terms of getting the. So this is one way of putting the lens in. So multifocal toric lens, as you can see. Now there are three ways you can dial a lens. One is to put the lens partially in the bag, partially outside, and then dial it into the proper axis, and then put the other two corners inside. Yet another way of dialing would be to dial on the optic haptic junction, or in this lens, I'm using the haptic itself and dialing on the haptic surface, avoiding the center. It doesn't cause any scratches, I can assure you, because I'm using two dialers. So you can dial using the dialing hole, one, or you can use dialing the optic haptic junction, if there is one, depending on the lens, or you can dial using the optic itself, as we demonstrated. Dr. Divya, are the videos visible?
Yes, sir, clear.
Okay, good to hear. I always insert the lens with a little support because some of the lenses tend to open up a little fast and explosively. So I use a dialer to prevent the lens from explosively going in. This is a complicated case with multiple synechiae. I'm a little aggressive with multifocal lenses, so even in those with uveitis, I use them. It happens when your confidence is a little high, maybe overconfident also. But anyway, that's how life is. So this is a dialing with using the haptic itself. Okay. So that's one more. You can do it single hand, you can do it two hands. There are any number of ways you can dial it, so long as you don't break the PC or fine. So now we come to a key point, which is going to be about rotation. The more number of points that the lens sticks to the capsular bag, the less it is likely to rotate. So if you have any toric lens which has a C-loop shape, modified J or C, it doesn't grip very well. That's one main disadvantage. So if you use a toric lens of the left type, the C-loop type, you're more likely to have post-op unstable axis maintenance. Whereas if you have a plate haptic lens, it's not actually a plate haptic lens, it's a kind of a modified design lens, then this particular lens is also a little sticky. It is not easy to dial. So those lenses which are not easy to dial because they're a little sticky, the important points to remember, you can use any lens of your choice. Now, why I prefer this, the Carl Zeiss 709, is because my entire experience has been with that. Initially, we used lenses of different designs and different companies. Many lenses like your Alcon, Abbott lenses came in very few selected cylinder numbers. Whereas here it goes from 1 cylinder to I think plus 12 cylinder in 1 cylinder stages. So today I put in a lens with a power of -2 plus -2 sphere with +4 for a lady, not today, 3 days ago. And the post-op was 6/9 partial unaided. And her best corrected vision was 636. She was diagnosed as amblyopia by my staff, by my doctors, and she was quite consigned to have 636 vision without glasses. So you can imagine the enjoyment and the happiness that comes. We only pray that it stays that way. Now, here is a key point that by myopes, it is risky to put in a lens and promise stability. The reason is these lenses are standard size and no eye surgeon ever has an idea or can measure the size of this capsular bag. So that is the problem. We presume it is something, we don't know what it is. In terms of a C-type C-loop, it will reset. But in a plate haptic, if you have a high myopic case, you should be very careful. If you use a high myopic lens, those are the ones that are likely to rotate unless the lens has been made about 14 millimeters, but these are 12.5 millimeters. So that's a point to remember. Now, one tablet of Diamox given perioperative or post-operative can bring the eye pressure down to near unrecordable, and I'm telling you this from repeated experience. So the eye literally becomes like a flaccid bicycle eye for a few hours, 1, 2, 3 hours. When the eye reforms, the lens shifts, okay? So the anatomy is deformed anatomy because of Diamox. Patient would not have touched it. They are using the shield or the glass, whatever. During the reformation phase, if the patient is lying on the right side, the lens will tend to gravitate towards the 9 o'clock position. If the patient is sitting or standing, the lens will gravitate towards the 6 o'clock and vice versa. So remember that Diamox is not to be used as far as possible because of the extreme hypotony that even one single tablet can create. It may not happen in all patients, but this is a good lesson to remember. The IOL rotations that I've had have only been in high myopic eyes. I must have re-rotated about 5 lenses in the last 15 years. So stability is extremely high if it is done well. So if you look at a matured practice, a matured cataract practice, not talking multifocal maturity, just toric, then maybe about 15% of your cataracts could easily be a top-line target. So if you're doing 100 cataracts a month, maybe at least 10 to 15 should be that. And that is a very broad guideline that one can set for yourself. In fully matured practices, it's usually around 20 to 25%. Depends on the confidence of the surgeon and the repetitive success in the results of glasses free vision.
And Bhanu sir, you have anything to add to give us so far about lenticular astigmatism?
Yeah. Basically, lenticular, once you do the cataract surgery, the lenticular astigmatism is gone. Because once you do a rexis and remove the lens, the lenticular astigmatism part is totally gone. So ideally,
Yes.
when you calculate the toric IOL, we usually take the K reading only. You don't have to bother about lenticular astigmatism. That means usually you get that astigmatism only by like AR, automated refractometer. When you take astigmatism, sometimes you get only 0.5, but you see the corneal astigmatism is more. That is neutral. The lenticular astigmatism is neutralizing the corneal astigmatism sometimes. But still, when you remove the lens, you will still have the astigmatism. So you should always You should always take the K reading as the component for the correcting the corneal astigmatism, not the subjective part of the astigmatism.
Okay.
So if there is any K1, K2 difference, you should more than 0.75. Those are the good candidates for toric IOLs. And preferably markings, what I do is I usually take a Topcon slit lamp only, not the Appasamy slit lamp, because the markings are not so good. And preferably in a sitting position, I usually use a 26 gauge needle and directly the toric calculation what we get. Preferably, as sir said, Mirlay sir, you need to have IOL master. For any premium IOLs, you need to have a optical biometry to give accurate results, and you are also confident that okay, I can give the best results to the patient. And always take the K1, K2 reading from even compare with Pentacam also when you are taking an IOL master, and see that it is near equal to the Pentacam. And there's a calculator on website, Alcon or Johnson and Johnson. Just enter the details, you'll get that. Most of the times, even there is an option of like post-corneal astigmatism. There is algorithm which Barrett has already included in the calculator. So we should not bother about the post-corneal astigmatism. Clinically, not a significant part which plays in giving the results, post-op results, when you consider post-corneal astigmatism. So I don't consider clinically much significant of post-corneal astigmatism. And preferably the whatever the axis the company has recommended in the website already, when you enter the data of K1, AC depth, IOL power, everything. So I usually take the 26 gauge needle and mark directly, no 0 and 80, directly on the Topcon slit lamp. If it is like 55 degrees, I make a 55 degrees exactly on the slit lamp and make the patient sit horizontal in a sitting position and mark directly the 55 degrees, no 0 and 80. I don't do that 0 and 80. Directly 0, like whatever the company has recommended, directly like 55 degrees, I go for 55-degree axis correction with the 26 gauge needle. And during surgery, what I do is that the rexis plays an important role to have a perfect centration. The 5.5 should not make a too large rexis, because if you make too large rexis, you don't know like whether that which is the perfect axis. So when you make a 5.5 perfect rexis, center rexis, your IOL fits very well in the bag. So you can exactly keep the IOL on the perfect axis which has been marked on the slit lamp, on the cornea. So that is one thing. And preferably what I do is put properly the visco, form properly the antechamber when you're rotating the IOL. Don't do under shallow chamber, because again it will rotate. So make sure that your chamber is fully formed when you are keeping your IOL into the perfect axis.
Thank you, sir. Thank you so much. I think it's time. Thank you for giving your valuable time for us.
Great. Thank you
And
very much, Dr. Divya.
thank you, sir. Thank you. And thank you, Dr. Preethi, for giving us this wonderful opportunity. And attendees, if you think that this talk was useful, please share this video with your fellow ophthalmologists. The video will be available in our Education Committee YouTube channel soon. And thank you so much for giving us your wonderful time. Thank you. Thank you all.
Thank you, Dr. Divya, and thank you, Dr. Bhanu Prakash.